Right. So when you talk about sorry. So this is what we are talking about. We are not mainly it's leiomyoma and adenomatous polyps, but adenomyositis, although we don't call it as a sort of tumor because we can't have an identifiable tumor, and that is of course dealt with another topic for you all on endometriosis and adenomyosis. That will be a separate lecture. Now, when you talk about fibroids, it is something that is very common. And it's perhaps the most common tumor of the female in the reproductive age group. Now it's as common as about 1/3 of females would have fibroids at some point. Okay, so it can be more depending on the populations, but generally at least at 1/3 of them of women in the reproductive age group is likely to have fibroids. It's quite common. 1 in 3 of women will have. Okay, so it's a benign tumor. It's not malignant. Okay, and the fibroids generally arises from smooth muscle and fibroblasts, and it arises from a single cell. Okay, and then you have this growth of this tumor, which mainly composed of smooth muscle, fibroblasts, and other things like collagen and elastin. It's a thing that is composed of many types of tissue. Now, when you now fibroids can when you have a uterus, the fibroids can be located in different places. Okay, now depending on where the fibroid is located, it can be in the muscle. We said it arises from the smooth muscle cells, and it can grow inwards towards the uterine cavity. It can grow within the uterine muscle. It can grow on the surface of the fibroid, subserosa, and you can also have a fibroid that is pedunculated. Okay, it can appear with a stalk. Okay. Now it can be classified depending on the location. It's classified either submucosal, intramural, if it's subserosal or pedunculated fibroids. It can also be classified with the new classification system. I'll come to that, depending on the new palm coin classification as well. Okay. Now this is where I spoke to you. There can be, if it projects in the uterine cavity, it's submucosal. If it grows within the uterine muscle, it's intramural. Or if it grows out of the uterine surface, it's subserosal. Okay. And then this is what I said. In this classification also, you have heard of this classification with the other abnormal uterine bleeding. Leiomyoma has a sub-classification in this palm coin classification system. Okay, so that basically depends on how much of fibroid projected into the cavity or not. Okay, so if it's submucosal, if it's completely pedunculated, it's not. But if it's less than 50, more than 50 into the intramural and less than 50 in the, sorry, more than 50 into the uterine cavity and less than 50 into intramural, it's classification SM1. It's more than 50% in the intramural, SM2. So likewise, you don't have to, you can just see this classification, it's there anywhere. So it's classified depending on the degree of extension into the uterine cavity or to the serosal surface, or whether it's into the uterine cavity. Because the important thing for you to know about this is because some of the symptomatology will depend on where the fibroid is. Okay. So we said it arises from the single cell, and what we know is the fibroid seems to have both progesterone and estrogen receptors, and there is some relationship with its growth with the kind of hormonal environment that is there, especially if you look at its certain extent, its growth is estrogen dependent. That is why if you get fibroids, say during pregnancy, it can grow. If it's and it is also the fact showing that it is related to the reproductive hormones, estrogen and progesterone, is because you don't find unusual to find fibroids before menarche, and also it's very uncommon in the postmenopausal period. And even if there are fibroids, once you attain menopause, they don't stop, they don't grow, and they stop growing. So that it's certain extent it depends on, it's depend on estrogen and progesterone as well. Okay, and these fibroids also tend to have certain vascular abnormalities with the uterine vessels. So there may be the role played by various vascular growth factors in the pathogenicity of fibroids. Okay, and stem cells also seems to be having a role. But these are all possible associations, and there's nothing to say this is the exact cause of the fibroids. Just in a second. Can we share? Share. Mother? Uh, 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 right, okay, right. Okay, right. Sorry about it. It's, I had to answer the call. Right. And then there are certain people who are more likely to have fibroids, right? Especially the fibroids are more common in people who are in black race, okay, than in white. I told you it's depends on certain extent on the estrogen receptors. The parity is important, okay. When you have nulliparity, in nulliparous women, the fibroids are more likely to happen, and if you have many pregnancies, it's less possibility. And you have early menarche is associated with increased risk. Okay, if you use certain things like long-acting progestins, it seems to have a protective effect. If you use low-dose progestin, sort of oral contraception, there is no significant association of that, because it's not, although you see, you use high-dose progestogens, so even oral contraceptives, it can have an impact on the growth, especially in pregnancy growth. Okay. Then there is thought that there is this is not actually related to factors now, because we don't sort of have people exposed to prenatal stilbestrol. That era is more or less gone. And there appears to be some environmental factors also lead to increased risk. And also, there are certain genetic factors tend to have a familial tendency. It's more likely in obese people. Okay. There is a slightly higher risk in people who consume a lot of red meat. Okay. But if you have consumption of sort of healthy diet, like vegetables and fruits, seems to have a reduction of the incidence. Okay. Okay. Then there are certain things like alcohol, which tends to have an increased risk. Smoking tend to have some protection. I told you it has a familiar predisposition of these women having fibroids. Okay? So likewise, there are groups of people who are at a higher risk. But it doesn't mean that these are the definite etiological factors, but these are more like associations you see that's more common in people who consume a lot of alcohol. It's more common in people who have a high sort of estrogenic environment, okay? And it tends to have a familiar tendency. All these are associations that we observe. Now, when you have fibroids, I said it's very common. It's common in the sense it's seen in more than 1/3 of women. And the important thing is most will not know that they have fibroids because they do not produce symptoms. So majority or nearly 50% of fibroids may not produce any symptoms. Okay. So, and because of that, very often these can be incidental findings on a routine ultrasound scan done. So that's why you just because you see a fibroid, you don't have to go and do surgery always. Because if it doesn't say produce any symptoms, it is not a malignant tumor. So it's very, it's in that case, you may not need to do any active treatment if they're not producing any symptoms. Okay. If they tend to produce symptoms, the production of symptoms or the symptoms that a woman might have will depend on where the fibroid is. Okay, in that when I say where the fibroid is, it is in relation to the uterine muscle, whether it's close to the uterine cavity, or whether it is intramural, or whether it is subserosal. So it will depend on the site of the tumor in the uterine muscle. It will depend on how big it is, and also the fibroids. Sometimes I said it's most of the fibroids are asymptomatic, but if it undergoes certain complications like degeneration or torsion, then because of the change of degenerative changes or because of torsion, then of course very often the symptom that they produce is acute pain. It can produce pain. Now, when you look at the symptoms that is likely to come with fibroids, there are about four groups of main symptoms you get. One, of course, they get menstrual symptoms. Okay. Now, menstrual symptoms, and I told you the menstrual symptoms are likely when the fibroids are close to the endometrium. So it's more likely in fibroids that are subserous. Okay. And then you have you can have sometimes bleeding in between your periods, and also you can have pain during periods. Okay. I said there are more than 50% asymptomatic. Then, of course, it can cause pain. Pain is more likely to occur when there are complications. I said if there's undergo torsion or they undergo degeneration, certainly fibroids can cause symptoms. Then, depending on where the fibroid is, it can cause urinary symptoms, especially if you have the uterus and you have anterior wall fibroid, you can have increased urinary frequency. And if you have a posterior wall fibroid, because this fibroid is in the pelvic cavity and when it enlarges, it can sometimes give you acute retention of urine. Okay. When the fibroids are quite big, when they grow, sometimes they can be quite big, and because of mechanical issues, it can cause certain pressure symptoms. Okay. Now, when it comes to infertility and fibroids, the relationship is there's no sort of a very close relationship with infertility, except in certain occasions. So if there is a fibroid that is projecting into the uterine cavity, certainly, and if it's a big one, certainly that might make the endometrium less favorable for implantation. And if the fibroid is at the origin of the tube towards the cornual end, when a fibroid goes at that point, it can interfere with tubal patency. So that's the kind of thing that might lead to infertility in when they have fibroids. So that's why when you, that's when I said the relationship is not sort of very clear. It has been clearly shown just because you see a small 2 centimeter or 3 centimeter small fibroid in the uterine muscle, it is not, and especially if it doesn't produce any symptoms, then just because of the fact that the patient is not getting pregnant, you going and doing surgery may not be really indicated. Okay, so that's something you have to keep in mind. So this is what I said, can produce menstrual symptoms due to various factors. Because when you have a fibroid, it becomes more vascular. It becomes, and when it projects into the, like this, it projects into the uterine cavity, it can increase the surface area of the endometrium. Okay. And of course, when you have fibroids projecting into the cavity, it can interfere with uterine contractions and hemostasis. So because of these factors, people with fibroids, especially in the submucous area, they tend to have heavy menstrual flow during the periods. This is what I told you earlier. I showed you that fibroids and infertility association is not very clear. It probably may be 1 or 2% of cases for the reasons I mentioned to you earlier. Either it might make the endometrium non-receptive or unsuitable for implantation because of the fibroid going into the uterine cavity, or if it's in a cornual fibroid, it can, if it's gross, it can interfere with the tubal patency. So these are things that might happen. Okay. So there are various theories. Don't worry about these extensive theories, but there are various theories that have been brought in for the possibility of infertility in case of fibroids. Now, other symptoms that the fibroids can cause, I said, is pain. Right? Pain is, I told you, pain can occur if there are degenerative changes. The good example is when somebody is pregnant and you have fibroids during pregnancy, they can undergo what is called red degeneration. And when they undergo red degeneration, it can cause pain. Then, especially if the fibroids in the subserous area and it sort of twists, there can be torsion, which can cause acute pain. And of course, rare possibility, I said fibroids are benign, but the risk of malignancy in fibroids may be less than 0.5% chance that the fibroids can undergo malignant change. Of course, if they undergo malignant change, it can also contribute to pain in these patients. Okay. I mentioned to you about urinary symptoms. If it's anterior wall, it can cause increased frequency, and if it's posterior wall, it can lead to urinary symptoms. Pressure symptoms, I did mention, depending on the size of the fibroids, and if they grow large, if they get bigger, because of the size and because of the mechanical impact that it's going to have, it can cause various pressure symptoms. Right. General wise, what you can get is, if the patient has heavy menstrual periods, if there's blood loss is high during periods because of the fibroids, for obvious reasons, patient gets anemia. And there's a very rare possibility. It's a rare phenomenon where they might even get polycythemic, because it has been shown that some of the fibroids can have erythropoietin-like factors which might stimulate condition of polycythemia development. Okay, so this is a very rare finding. So don't go and say that's the first thing. But for people with HIV periods, more likely that they will get anemia, but in extremely rare situations, this is also possible. The fibroids can undergo certain changes. Now, when you have a fibroid, they can undergo certain changes. The main changes it can undergo is either it can undergo atrophic changes. Now, atrophic changes are likely when you have a patient who is having close to menopause, and when you menopause, gradually the fibroids can get smaller and atrophied. I said they can undergo degeneration. Degeneration, the sort of best example is that occurs during pregnancy, where we call it's undergoing red degeneration, and rarely it can undergo malignancy. But the risk of malignancy in cases of fibroids is less than 0.5%. Okay, so just because you have fibroid, you are not going to get a malignant change in the fibroid. Risk of these changes are extremely rare. So I said it's less than 0.5% chance. Okay, there are different types of degeneration that can occur, and the commonest being what's called a hyaline degeneration. And there are so many different types of degeneration that can undergo. And I said, in pregnancy, what is the type of degeneration that is likely to happen is red degeneration. Okay. Okay, and I said they can undergo other complications like torsion. This is more likely in cases of subserous fibroids. Okay, and you can produce, when you say inversion, you can produce uterine inversion. Okay, what happens is if you have a uterus and if you have a fibroid which is attached to the fundus, and it keeps on growing, and with period of time it can drag the uterine fundus down, and it can invert the uterus, which they call it a chronic uterine inversion. You can, acute uterine inversions can occur postpartum. If you say like that happens when the fibroids, when the baby is delivered and the placenta is attached to the fundus, if you just start pulling, it can cause inversion. Similarly here, if the fibroid is attached to the uterine fundus, it can keep on applying sort of traction on towards downwards, and over a period of time, it can undergo chronic uterine inversion. So these are two different things with two different outcomes. And also the fibroids can have infection as well. Okay. Now, specifically, if you get pregnant with fibroids being present, there are certain problems that can occur. Okay, I told you at the beginning, infertility and fibroids relationship is unclear, right? But certainly, when they are pregnant, you can have problems from early pregnancy. There's a slightly higher risk of miscarriages in this patient who have fibroids. As the pregnancy advances, you can, as the patient sort of goes towards the second, third trimester, then you can have problems because of the fibroids causing mechanical problems. Okay, because if there's a fibroid projecting into uterus, it can avoid baby turning inside the uterine cavity. It can sort of resist the turning, and it can lead to malpositions and malpresentation. People with fibroids are likely to have preterm labor. I said they can have pain because of degeneration that can happen. When fibroids are subserous, so you have something inside the uterine cavity. Especially after delivery, it can interfere with the uterine contractions. Okay, and it's also known that it can increase the risk of preterm pre-labor rupture of membranes, risk of operative deliveries, risk of postpartum hemorrhage can be depending on the site of the fibroid, and rarely uterine inversion. Right? I said it can be a chronic uterine inversion, right? Gradually pulls up in a non-pregnant uterus, but rarely you can have if the fibroids attached to the uterine fundus, and especially if you start pulling, you can cause uterine inversion as well. Okay, so that is something that is can happen when you are pregnant. Okay? Now, if you suspect somebody having fibroids, you obviously first thing is your clinical examination and a good history taking. Once you take a good history, you should be able to assess what the symptoms are. And also, then if you suspect the possibility of fibroids, you may need to think of going to certain investigation. And the commonest investigation, of course, that's been done for suspected any pelvic mass is the ultrasound scan. Okay, so once the ultrasound scan is done, and if you have uncertainties, especially with these ultrasound scan findings, then you have the option of proceeding to the next couple of investigations like a CT and MRI. And word of caution with CT, of course, you know, CT scans carry a high risk of radiation. So you have to think of be careful when you are using CT scans. Okay. MRI generally safe, but having to do MRI or CT for a fibroid is again rare. Most of the findings with the ultrasound scan, you can manage a patient with fibroid. So doing CTs and MRIs are often of academic interest. Right. And then if you are not sure what the tumors that you are talking about are there, is you can also do have a look through a laparoscopy and then confirm your diagnosis if you are not sure what the pelvic tumors are. But present day imaging is quite accurate. You can certainly manage with your ultrasound scans and the CTs and the MRI. In situations where you suspect having a submucous fibroid, it's like what you did a laparoscopy when you have a fibroid that is in the abdominal cavity. If you have something within the uterine cavity, then of course doing a hysteroscopy, putting a telescope into the uterine cavity and having a direct look certainly helps to sort out what this where these fibroids are. So you have this, of course, you don't have to do all these investigations in a single person. In most situations, just doing an ultrasound scan is adequate. Okay. If you need any confirmatory thing, you may look at other investigations and also go into their history and to make sure that they have no other problems. What you do will have to be decided depending on the individual patient. That's something that's very important. So you don't have, I said ultrasound scan is most often it's adequate, but select whether you want to do MRI or a hysteroscopy or CT, depending on additional questions you want answers for. Okay. Right. So if you have fibroids, what do you do? Now, I told you earlier, most of the fibroids are asymptomatic. So if they are asymptomatic, just leave it alone. Okay, so that's why just because you see fibroids, you don't have to operate. Whether you want to operate or not will depend on these factors. One, of course, what symptoms are produced by the presence of fibroids, how big the fibroids are. The treatment also will depend on where the fibroid is. When I say where the fibroid is, whether the fibroid is in the submucous region or whether the fibroid is in subserous area. So depending on where this fibroid is, it can produce different symptoms, of course, and the need for treatment can also be different. And of course, age is a determining factor. If you are 65, you have the fibroid, you may not even touch it. Then mostly in younger people, their reproductive wishes are important. When I say reproductive wishes are important, there are two aspects. One is, of course, now question is whether the presence of a particular fibroid is making her subfertile or infertile, right? The second thing is, important thing is, now just when you have a fibroid, if you just go and operate, the consequences or the complications and the problems like adhesion formations that can occur with the fibroids. Okay, so you have to think of what symptoms they are being produced, where the fibroids are, how big they are, and of course think of the age of the patient, young to over 70s, and whether there are plans of having a pregnancy. And very importantly, we are always worried about, although we said it's 0.5% chances undergoing malignancy, we need to be vigilant about it. And of course, if you find a fibroid that is growing fast, then you have to be suspicious. So rate of the growth of the fibroid is also something very important. And whatever the management of fibroids, you have to individualize, because you have to individualize. When I say individualize, you are talking about putting them, sort of taking them for treatment depending on their symptoms, depending on the size of fibroids, and of course, depending on their reproductive wishes, whether they want to plan a pregnancy or not. So all these are important things to consider when you decide on treatment for a patient for fibroids. These are, I said, majority of the leiomyomas are asymptomatic, and we often they don't need in treatment. Now, when you go to treatment, okay, now there are several options of managing the fibroids. One, of course, do nothing. Okay, I told you earlier, if there are fibroids, you find it on a scan, they are not producing any symptoms, just do nothing. It will not disappear. But the generally fibroids go at a very slow rate, and on average, if you take the fibroids grow at a rate of about 0.5 centimeter per year. Okay, so then it's a very slow growth. You don't have to jump and operate. You can do a medical management. When you talk about medical management is mainly not to get the fibroids treated or get the fibroids disappear, but medical management is mostly used for symptom management. If for example, if the patient is having heavy menstrual periods, then you want to, even if the fibroid is there, you want to reduce the menstrual flow. So you can use drugs or medicines to control their symptoms. Okay. Ultimately, surgical management is a fertility management. Then there are different types of surgeries you may perform, and also radiology, also interventional. When I say radiology, interventional radiology also has some place. When I say it has some place, for example, with a various embolization techniques. Okay. I told you expectant management for asymptomatic fibroids. Then if you are, as I told you at the beginning, if they are 48 and you have a fibroid, then they're not producing any symptoms, you can just watch until they become menopause. Okay. When subsequently you can see a reduction in the size, especially after menopause, so that you can manage conservatively. Okay. I told you when you are managing conservatively, most of the worry the patients have is when they come and ask you is, will they become cancerous? Okay. None of us can give a sort of 100% assurance, but we know the risk of a fibroid becoming malignant is very low, less than, I said, less than 0.5%, and some of the studies have even showing close to about 0.2%. So it's not a common thing, so you don't have to act on that. Okay. I said you can use medical management with various medicines, and all these medicines are directed to reduce the symptoms that the patient is having. Okay. So you can use medical management in the sort of perimenopausal period. You are sort of managing 3-4 years until she attains menopause. Okay. Of course, if they are not fit for surgery, or if you are on fertility treatment, you can temporarily use medical management. And rarely, and I wouldn't say rare, but other place for these medicines in terms of the fibroid management. When I say medicine, various drugs that you use, maybe generic analogs, maybe other sort of danazol and other many drugs, will come to that. Those are important depending on what you want to do with the fibroids, because that we know certain medicines, if you use on these patients, it can reduce the size of fibroids. Remember, it can reduce the size of fibroids, but it will not make it to disappear. But the important thing is you can reduce, but when you stop the medicines, it can start growing back again. Okay, so that's something, if you're thinking of medical management, remember, it's not a permanent cure. Okay. Okay. And then the drugs that you use, I said, the most of the common symptom that the patient have, troublesome common symptom with fibroids is heavy periods, and then you need to give medicines to reduce the flow. So one of the drugs you can use is antifibrinotic agents like tranexamic acid. Then you can use danazol. You can use combined oral contraceptive pill. Okay, so if you put on the pill, you know the pill, the menstrual cycles with the pill generally have less flow. So if the symptom is heavy menstruation, is like what you use the tranexamic acid, you can also use oral contraceptive pills. Then you can also use danazol, I told you earlier. All these are temporary measures. So whether you use tranexamic acid or the pill or danazol, it will temporarily reduce of the fibroid, and also it will relieve their symptoms. Generic analogs are being used. Generic analogs, you may have heard of generic analogs. They are structure that is similar to generic, and when you give it sort of repeatedly, when you keep analogs in the circulation for some time, it can cause reduction in the FSH-LH levels. With that, you can create a hypoestrogenic environment. With this hypoestrogenic environment, of course, fibroid can get smaller. Okay, I told you they won't disappear. But the important thing with using this generic analogs is you can't use it for long periods of time, because its effects on the bone, it can cause osteopenia. It creates like an artificial menopausal status. So because of that, the sort of general period that these genetic analogs can be used is for about period of about 6 months, right? So it's not something that you can use long term to medically manage fibroids. These other drug that is being sort of, although locally we don't have this drug because basically it's a drug that we use for terminations also. Because of that, it's not freely available, but you can use selective progesterone modulators. One of the best examples is mifepristone to treat the patient and reduce menstrual loss in a patient with fibroids. If the uterine cavity is not altered, right? If suppose you have a 45-year-old patient and normal uterine cavity, the fibroids are outside, right? The not projecting the uterine cavity, then of course you can sometimes use this what we have called heard is like a Mirena or neurogenital infertility systems for management and of heavy menstrual loss, right? So as you would have seen, the most of this medical management is to control their menstrual symptoms. Okay. Okay. The newer drug in the sense that's not been something that's used in the past. The drug is not new, but uripristal acetate also a drug that can used to reduce the size of fiber. So you can use either generic analogs or even uripristal acetate, mifepristone. They always will control symptoms, and also it will, to a certain extent, reduce the size of the fibroids as well. Okay, it's like many studies have shown, uripristal acetate, even if you go a short period of time, it can have an impact on menstrual flow in over 90% of cases as well. Okay. Right. Now, when you look at surgery, so medical management, you can use tranexamic acid, you can use the bilateral contraceptive pill, you can use mifepristone, then you can use generic analogs, okay. You can use uripristal acetate. And so there are many different medical therapies available, and I told you earlier, those medical treatment is available to reduce the menstrual flow. Now, surgery is I said the surgery is the sort of a final definitive answer. Now, when you want to do surgery, you can do surgery by basically you want to take that fibroid out. So there are different access routes proposed for surgical management. One is, of course, the sort of traditional low suprapubic incision, which is the phalangeal incision to do open myomectomy. Or you can nowadays select your cases. Remember, select your cases, and in selected cases, you can do the removal of the fibroids laparoscopically. Okay. Then, if the fibroids are now not like this, now this is something outside the abdominal cavity, but if the fibroids are projecting down and still in the pelvic cavity, you can approach it vaginally sometimes and do a vaginal myomectomy. And I told you earlier, you can use the hysteroscope as well. Okay. Now, you say, when I say hysteroscope, you can use, now if a fibroid like this, okay, you can put the telescope, which is a hysteroscope, into the uterine cavity and cut these in pieces. Okay. and take it out. Okay. So you can surgery you can do abdominally, laparoscopically, vaginally, or hysteroscopically. Okay. So there are different approaches you can come. Now, which route you are going to do this surgery will depend on where the fibroids are and what symptoms are produced by these fibroids. Okay. Now here we spoke about removing only the fibroid, which is called a myomectomy. But certainly, if the patient has completed the childbearing, you can give a final answer by doing a hysterectomy. Now, very important for you to counsel this patient who are coming for management of fibroids, because whenever they sort of discuss the surgery, what they want to know is, okay, right, you have now fibroids in the uterus. We are going to do a cut and remove those fibroids. Can I get it again? Okay. Yes, you can get it again over a period of about 5 years. The reappearance of fibroids seems to be around 7 to 8%. Okay. Sorry, recurrence rate comes about 15%. Okay. Now it's important for you to tell the patient about the possibility of recurrence, because otherwise they will, especially this is important when you counsel people in the reproductive age group, latter part of the age group, right? Certainly, if the patient is 25 or 30 years, all the efforts should be to do only to remove the fibroids and only do a myomectomy, accepting the fact there is a 15 to 20% of recurrence. But when it comes to 40s and early and latter part of 40s, if the patient has completed the family and they are not planning for any further pregnancies, then you have to really discuss the option of removing only the fibroids and having a possible recurrence compared to doing hysterectomy where there is no recurrence. Okay, that's something important. I told you earlier that different routes can be used laparoscopically. You can do it laparoscopically. You can do open myomectomy. So you can do surgery laparoscopic, open, vaginal, or hysteroscopic. Select the route, select the access depending on where the fibroids are. Okay. Now this is where I said you can do a hysteroscopic myomectomy. And what you do in a hysteroscopic myomectomy, you see this wire loop. You do what is called the resection. You have a wire loop, which is a heated wire loop. So with a heated wire loop, you can keep on cutting pieces and then do it. Okay. Now, of course, there are new developments in the field, and now there are new instruments that are available, although we don't have it at the moment, that you can do a sort of have a rotating ball inside the putting it through the hysteroscope and do a hysteroscopic myomectomy. Okay, so there are different ways you can do, either cut piece by piece and then or do a different instrument and put it like a it's where you can put it through the hysteroscope to resect this myoma hysteroscopically. Right, and then you can use. I said you can use certain radiological methods to manage these fibroids. Now, when you talk about radiological methods, it's really what the basic principle of using radiological methods is to obstruct the vascular supply. Okay, so if you obstruct or if you block the vascular supply, then the fibroids will not go further. Okay, So this is by using embolization of the vessels. Okay, so we can use what's called selective uterine artery embolization. So there are certain advantages and disadvantages of embolization. If you are doing embolization, you have to catheterize the vessels and identify the feeding vessels, and using different pellets, you obstruct the vascular supply to the fibroids. Okay, so this is something, just a diagram you can use. You can use this catheter, and you catheterize along it, and then you basically find the feeding vessel, and then you try to block that feeding vessel. Okay, this is not something that is very commonly done in our practice. It is offered either the patients who are not fit, or if you are using selective uterine artery embolization, you have to select the cases. So if a patient has sort of 40 fibroids, then trying to do a uterine artery embolization is fruitless. But you have a single fibroid, which has, for example, you say she has single 5 centimeter fibroids, right? You can say she's not fit for surgery. Then yes, this kind of technique is useful to manage the fibroids. Okay. Rare techniques are either burning the fibroid and myolysis. Okay, and there are certain new techniques that have come. If you look at some of the treatment that is available for cerebral tumors, meningiomas, like what you talk about, the stereotactic radial surgery. Here also, you can use magnetic resonance guided ultrasound surgery. So basically, it's like delivering a high energy to the fibroids, and of course to sort of you can reduce the fibroid by treating this fibroids, basically making it avascular and ablative. It's a particularly the word is like ablation technique where you destroy this fibroid. Okay, so you can, I said, you can use do nothing. You can use medical therapy, which is mainly to control symptoms. You can think of doing surgery. Surgery may be abdominal, maybe laparoscopic, maybe vaginal, maybe hysteroscopic. Okay. Then you can use different ablative embolizations, interventional radiology. Then you can also think of using like MRI to treat the fibroid. Okay, and I told you, if they're not planning for further pregnancies, then of course the final answer may be removing the uterus. Of course, you know, if you remove the uterus, there's no potential for childbearing. So you have to seriously consider. That's why this treatment, I told you, has to be individualized, and you have to select the cases and individually see what they are sort of reproductive issues and things before you treat the fibroids. Okay, so hysterectomy, I said, it's a thing that is, if you don't want children, if you have 50 fibroids in your uterus, just think of doing a hysterectomy, which either very often, if there are multiple big fibroids, it will be a abdominal hysterectomy, or sometimes you can do it through the laparoscope. Okay, then I very quickly, little time we have, and the other benign tumor that we talk about is endometrial polyps. They are just growths into the endometrial cavity, which has small growth, right? And these are, in these endometrial polyps can produce various symptoms. Very often they produce intermenstrual vaginal discharge or bleeding in between your periods, something like that. And histologically, it has the glands, stroma, and of course vessels. So these endometrial polyps are common in latter part of the reproductive age, like beyond your 40s, and there's no exact reason why they come, and like even the fibroids, we don't know exact reason, and it can be asymptomatic, but if it produces symptoms, very often it produces bleeding in between the periods or some kind of vaginal discharge. There again, almost all the time they are benign. Extremely rare possibility, we said even for fibroids, less than 1% chance. They are very rare to become malignant. Okay, but of course you have to when you see something in the endometrial cavity, you have to see what it means, see whether other things are also possible, like maybe retained products, maybe a malignant lesion like this. So ultimately your diagnosis or exclusion is by doing histology after removing. So these fibroids, very often you can put the telescope inside, and what you have is to do a polypectomy through the hysteroscope. Okay, so that's what we need to do for fibroids. Right. I said regeneration is something that just pick two questions. Regeneration is something that is occurring in pregnancy. What is thought is, I said it's a estrogen dependent tumor, and during pregnancy it can enlarge in size and it can create a relative ischemic changes. So because of this ischemia to the fibroid, that is the theory behind the red degeneration. Because of the ischemic changes, it can cause red degeneration. Okay, right. Fibroids occurring after menopause. It's what very often what you find is the fibroids would have been there. Suppose you do a scan in a 55-year-old one and you find a fibroid. Very often that fibroids would have been there even before she was getting menopausal, and very unusual for a fibroid to grow after menopause. I said it's a hypoestrogenic state. In the low estrogen level, generally fibroids do not grow after menopause. If it's growing after menopause, you must always suspect it undergoing sarcomatous change. Okay? So new fibroids coming after menopause, it's very, very unlikely. I mean, anything can happen in this world, but it's not something that is known to have fresh fibroids after menopause. Yes, focused ultrasound ablation certainly spares the uterus for childbearing. Yes, MRI. Yes, it's like I mean, I don't know whether you had it. Even for cerebral tumors, you do what's called like a stereotactic radiosurgery. That's where you direct these ultrasound beams from different direction and focused into just one particular point. Okay, and that will ablate the tumor. Okay, right. We just finished on time. You have another lecture now? Yes?
Yes,
huh?
sir. Yes, sir.
All right, okay. You have to join that. Who's doing it?
Dr. Jayawardhan, sir.
Asanka, right, okay, right. Okay, then my test join. Okay.
Thank you, sir.
Right. See you.
Recording stopped.